stage Tom Beauregard.
Thanks. Thank you. Good morning. I'll actually start just by picking up on the Q&A from Denise. And we're actually doing a fair amount of work, and this connects obviously to Mark's comments this morning in voice and vision. And with a couple of populations that we're really fixated on, and Denise said this, one is the elderly population, in our parlance, the Medicare population, where we are trying to help people age gracefully in place. And massive privacy concerns. I will tell you, in the sort of early stage experimentation that we're doing in this, that population is worried about surveillance. I mean, somebody asked that question. So to me, that's part of the biggest challenge. But the sort of the benefits in terms of things like medication adherence, support with mobility, and even loneliness. I mean, one of the small studies that we're running now is with a population that's alone, living in place, and loneliness obviously leads to depression, which leads to lower compliance, which leads to all kinds of terrible outcomes for people. So there's all kinds of applications, but the challenge isn't so much the technology, I think, early on. It's getting people to accept what they view as surveillance, because that's creepy, right? No matter what you say about sort of how their data and privacy is protected, it doesn't feel right. And that's a little bit generational. But then the other, and Denise touched on this, population that we're focused on is with veterans, right? So the idea of, one study that we're working on right now is around post-traumatic stress, and literally being able to use facial recognition, so I'm shaving in the morning, and it can sense my mood and identify whether or not a behavioral health person should reach out. So there's all kinds of applications, really cool stuff, but a lot of challenges around people accepting this kind of technology. So I'll start, and really my objective is a couple of things here. Just give you an overview quickly, and I won't spend a lot of time on this on UnitedHealth Group, because I think a lot of people think of us just as an insurance company. But then second, talk a little bit about how across the enterprise we kind of focus our innovation efforts. And then third, and I think most important, I'll give you some examples that are really, really tangible. And these aren't products that are in market. These are real R&D efforts that we're making in different spaces. Some of them are very high tech. Others are very low tech. And I did that intentionally. I just want to show you some of the things that we're working on to give you a flavor for our agenda. So from a overview perspective, what's unique about UHG is that we are sort of two very large organizations combined, right? We're the largest health insurer, UnitedHealthcare, in the country, right? And that's in any market, commercial, group, individual, Medicare, Medicaid. So a very, very large health insurer. And that represents about 60% of our business. And the other 40% is Optum. And Optum is really a technology and health services entity. So what Optum does is provide clinical services, disease management services, and a whole series of sort of consumer engagement and other solutions. We're really, really big. And I think most folks know this. We're Fortune 6, about 225,000 employees. What people don't generally understand about United is that we have about over 60,000 clinicians. So, and that's a combination of acquiring practices that we've been very fixated on trying to break down the fragmentation that exists in healthcare, because it's part of the problem. So we have primary care practices across the country, retail in the form of MedExpress, but we deliver a lot of healthcare service. So back to the point that it's a unique kind of health enterprise. And I really view it as a health system. And I think that's what makes the innovation opportunity so powerful for us. Because if you think about it in sort of simple terms, right, the insurer side controls sort of design and reimbursement. And the health delivery side is the actual care. And what's easy for us as we sit sort of at in the innovation arena at United is when we want to do experiments, and this is so basic, it's easy, right? I can do a reimbursement experiment with a practice that we own using members within UnitedHealth, obviously with consent. So when we start to do sort of R&D, we don't have to, at least within the health arena, look for a lot of external partners. We need external partners in a lot of other arenas, but that's really the power of UHD from an innovation perspective. When we think about sort of orientation, and this is obvious, it's not whole cloth. We've got a lot of problems in healthcare. Everyone knows it. And so what we've done, and innovation isn't centralized. I'm the Chief Innovation Officer, but really my job is to make sure that we sort of understand what's happening across the enterprise. We connect projects where they need to be connected, and then we help them scale. And that's another thing that we're really good at, just given our size. And that gets to a point that was made this morning, this idea that, R&D, it's hard to get sort of pilots or studies or basic experiments into the businesses. United is a tremendously well-run organization. We're great operators, and we scale really, really well. And not just our ideas, but outside ideas as well. So I said there's a lot of problems, and this is overly basic, but we all know that we've got both a baseline cost and a trend problem in healthcare, not just in this country, but globally. We have tremendous variation in cost and quality, and this is something that consumers don't generally understand. But if you look at, simple shoppable services, right, like an MRI or a colonoscopy or a knee replacement, and you look in specific markets, not outside of markets, but specific areas, 300% variation, not unusual from a cost perspective. So consumers don't understand the basics of health insurance, right? 50% of consumers don't know still the difference between a deductible and an out-of-pocket. I mean, the health literacy is so low. And then beyond just the insurance design, we're hoping that they can navigate the variation in cost and quality. And that gets to the overly complex consumer model. It's dense, and there are a lot of reasons for that. Some of them are regulatory, some of them designs that our industry has perpetuated over time. And then the final point here, and there are other problems, but these are kind of at a macro level, what we're focused on is compromised access to care. And that's, whether it's a rural area or whether it's specialist shortages, we know that populations can't get to care in the way that they should, which leads to all kinds of, terrible clinical outcomes for people and higher costs for the system. So my point isn't to try to drill down on these. We all know about them. It's really just to say that we don't innovate from a perspective of sort of, let's develop something cool, let's work with a sexy startup, let's partner with a customer because that would be helpful. We do focus our enterprise-wide agenda on system improvements. And this gets to this point is we can't do it alone, right? I said up front that we're a unique health enterprise, but we also understand what we can't do, whether it's a reputational issue, whether it's a distribution issue, whether it's a technology platform. We do a lot of very specific partnerships in those problem areas. And the Emmy that I actually won was tied to a program that we did with NBC around prediabetes. And the whole purpose of the program was to say we had worked to scale a evidence-based program called the Diabetes Prevention Program for people that are pre-diabetic. And the basic premise of it is if you're pre-diabetic, right, your chances of converting to diabetes quite high. But if you can lose 5% of your body weight, independent of what your weight is as a pre-diabetic, you reduce your chance of converting to diabetes, which is really hard to manage, and it's grisly, right? It's 10 to 15 years off your life, basically, on average, by 50%. If that were a pill, right, it would be worth an awful lot of money. And so we spent a lot of time as an organization trying to figure out how do we get the diabetes prevention program out into the system, out into the world. We'll pay for it. And we did a deal with the Y where we delivered it in group models, and that worked pretty well, but it was hard for people to actually get to a Y for a 6-month period. So we saw like a drop-off in the rates. So then we said, let's create a virtual program. Let's create something that people could get on demand through Comcast, and we did that with NBC. And it was like a reality TV program. So all the sort of evidence was delivered, right? We had 6 real pre-diabetics going through with coaches on this program, and we produced 13 shows. And then we did a full clinical trial where we enrolled about 1,000 people to actually participate using the Comcast system on demand. And what was fascinating about this was, you talk about vision. One of the things that the Comcast people were able to deliver to us was we knew if Tom was enrolled in the program in the trial, if I came in the room and turned on the show, right, I got credit for watching the show. If I left the room, the camera knew that and reported it, right? All with consent. So these were people that were within a trial. But what we found through this was just tremendous results because, one, it was easy, right? On demand, I can watch these programs, I can get the content when I need it. But more importantly, it was entertaining. And that's something that health insurance companies kind of miss, right? We try to deliver content, but that was the basis for the Emmy. But my point here is, and in that example, what didn't we have, right? We didn't have distribution, and that's what Comcast offered, and we weren't entertaining, and that's what NBC offered, right? So when we talk about partnerships, we just look for assets that we don't have. And it could be a new technology that we look at, a new device. But we do a lot of this, but it's always in the service of solving a problem that's specific to the member. Okay, so let me give you some more examples, and I jumped into some just in the opening, and I won't spend a lot of time on these because I would like to leave some time for questions. And they're all a little bit overly detailed, so I'll just kind of high level them for you. If you look at what's in the FDA approval pipeline right now, right, for specialty drugs and for devices, from a clinical outcomes perspective, it's incredible, right? I mean, it's so exciting to see sort of what specialty drugs can mean for individual health and lifespan. But it's also terrifying in terms of sustainability, right, cost. And we've seen real examples of that, right? And clinical trials tend to be, I would say, they have perfect populations. That's the only way I can describe it. And so we're doing a couple of different things. The specialty drug space, and I've got a couple of examples on this. As specialty drugs get approved, we are working to get into bundled payment, meaning not fee-for-service, value-based. If it gets the outcome, then you get the payment. And that's important. So that's kind of an insurance perspective, but it's good for the consumer as well. The second thing we're doing in this area, and this is a delivery model, but it's home infusion. So a lot of specialty drugs, all specialty drugs really have to be delivered in a hospital setting. There's a lot of waste from a drug perspective, and there's a huge time commitment for the consumer who's dealing with a lot at that point anyway. So one of the things that we've done, and we did this recently with a group of GE employees, is home delivery. And we've got a company called Accellacare that can actually do the infusions in home. And that's great for the patient. And I can tell you there, like back to the consent points I was making, people that are sick, or if their kids are sick, if they can stay home because these infusions take hours, it's huge from a net promoter score, from a consumer sort of perspective. It's a great thing. From a financial perspective, some of these drugs, when they're delivered at home, it's $50,000 a year in savings, which is great for the system. It's great for the consumer. This relates to it. Phase 5 research is basically back to that FDA approved. It's kind of a cute title. If you know anything about sort of the FDA approval process, it's a 4-phase process, right? To get whether it's a device or a specialty drug through the FDA. What we've done with our data, and because we're so large, we have credible data in every market, we're basically studying the effects of newly approved devices and drugs. Because what happens in a clinical trial versus what happens in the real world is very, very different. And we want to understand that. So we've handed our data over to a group of clinicians and economists at Northwestern. And we have no control over this, so we're not defining what studies, we're not defining the outcomes, but we're basically contributing our data to understand sort of what happens when a new pump is introduced or a new specialty drug is introduced. And what that will lead to is better advice for clinicians and better advice for consumers. Okay, a little bit more tangible. I talked about the problem of variation in cost and quality, and the fact that consumers never get it. And I will tell you that we have spent probably $100 million on tools for consumers to understand. My example about an MRI, if Tom Beauregard needs an MRI in a particular market, then I can go out to the UnitedHealth site, and there's data out there that will show me where I should go, how it will impact me from an out-of-pocket standpoint, if there are any quality differences. No one uses those tools, right? Because you have to go find it. And it's coming from a source that maybe they don't trust, just to be candid. So we get about a 2% utilization rate on those tools. We have the data, and they're slick from a consumer experience perspective, but the utilization rate is terrible. So we're doing a lot of work in this area to try to bring that data to consumers at the point of referral. And so we've got a whole series of randomized control studies going on in this area. But the basic premise is Tom Beauregard's walking out of a primary care physician's office with a referral for an MRI or a referral for another service. And what comes to me through the office manager or through that primary care physician is that data. So it's really just, this is pretty low tech, right? It's just putting the data and the transparency tools in the hands of a trusted source at the point of need. And from a consumer perspective, I go to the really basic examples. You can have easily $1,000 difference. So that individual, and you think about the average savings that people have, right? And you think about what the health insurance designs look like, right? It's still one of the leading causes of bankruptcy for people that are insured, right? People don't have $400 in savings. So that kind of information at the point of referral is really, really important. And that's just one example. We have a lot of work in this area. We have apps that we're developing that trigger when someone comes out. But the premise here is let's get this data out of our hands into the provider's hands and into the consumer's hands in a much more effective way. Okay, the next one is maybe of more sort of specific interest to a technology audience, but we're spending a lot of time now with FDA-approved devices trying to help people manage chronic conditions. And I've got countless examples of this. I'll just give you one or two. But right now, the way it works, if you have a chronic condition, you generally see a specialist, if you're lucky, every 3 to 4 months, and they ask you how you're doing. And what do you say? Right? One, there's a bias to say you're fine. Two, you don't remember, right? You can't really repeat sort of how you've been doing, whether it's blood sugar or whatever the issue is. It's bad information and it's bad access. Or the second model is a nurse from the insurance company calls you and asks how you're doing, right? The telephonic model. There's no data. You're unlikely to pick up the phone. And so what we see with chronic conditions is terrible outcomes, right? And that's, there's growth in this category of chronic conditions that's tied to obesity, that's tied to age. But we know that people with chronic conditions, it's really difficult to be compliant. So a lot of the work that we're doing in this area is using devices, FDA-approved devices. And so in this example, this is with Children's Hospital. We've got a study underway with kids with asthma. Kids with asthma, huge population. They tend to wind up in the ER quite often. They get really, really sick. It could be deadly. They're not well monitored. So what we're doing in this study, we've got, again, a couple of variations on this one, is we've enrolled families. So kids have a inhaler with a Bluetooth-enabled cap in combination with an activity monitor. And so we're able to see not only how frequently they're using the inhaler, which is a trigger for a problem, but also test pulmonary function. I mean, some of these devices are just amazing, but we're also able to see what's leading to it. Are they, is Johnny on the playground? What's the activity level? And what happens is we're able to then do outreach through Children's Hospital to the school nurse or to a parent to intervene. And that's really the basic premise. It's real-time monitoring using FDA-approved devices. And I can tell you, To the point I made about consent early on, this particular trial filled up within 3 weeks. And why is that? Because it's the parents that are managing for their kids, and it's scary. So it's so funny, and this is, again, overly basic, but it depends on the population. When we do studies with children who have serious conditions, the enrollment rates are really, really high. When we do studies with adults, diabetes is probably the best example, very, very difficult. A second example in this same kind of digital health category is in pain management. So this is one with Cornell Tech as our development partner and Hospital for Special Surgery in New York. Basic premise here, without taking you through all the slides, is we've got an opioid addiction, abuse problem in this country that is trending at a really scary rate. And if you look at the data, right, if we look at our data, and we do all the time in different markets, I think people have this bias, uninformed folks have a bias that it's lower income people, it's younger people. The reality is it's not. It's middle income, it's high income, it's all age groups, and oftentimes where it starts, if you look at the data, it's with back pain. It's orthopedic issues that people start on opioids and then lose control over time. So this is a basic model where we're saying, and it's called fresh backs, basically. People come in, and this is a clinical study that we're doing, to the Hospital for Special Surgery for the first time. They've got a back problem. They're offered enrollment into a study that says, instead of giving you opioids and telling you to go home for 2 weeks and call me, would you be willing to take some technology out the door? And what people want at that point is relief from the pain. This study filled up very quickly, and the basic components, and it goes right on someone's smartphone. It's an activity monitor. We can see if they're moving, right? It's a daily survey that happens several times a day to sort of measure their pain, and then it's virtual visits with a physical therapist from Optum. So if we're seeing that someone isn't moving, right, we're able to actually monitor them. We can reach out and say, hey, Tom, are you all right? Do you want to do some stretching exercises? Can we make an appointment back with your specialist? And we've got very immature results on this, but I will tell you that people are using these apps at an alarming rate, and they're also enrolling in the study. So this is a pretty basic one. It's a series of stacked apps on your smartphone, but it's targeting a very specific problem that leads to unnecessary surgeries and addictions. Last one in this category is for type 1s, again, mostly kids, also with Children's Hospital, but this is a insulin pump that actually is Bluetooth enabled that reads sugar levels coupled with an activity monitor. So it's the same idea. Instead of having to see an endocrinologist every 3 to 4 months and get feedback on sort of data points that you don't have, this is real-time monitoring. So this, to me, is the future of disease management. This is what will make a difference both from a patient outcome perspective and from a cost perspective, because disease management in this country, as it's sort of geared today, doesn't work very well. Last one, no, I've got 2 more. Next one's low tech, group prenatal care. This one's, I think, incredibly cool. This has been and it's one we didn't invent, but if you look at our preterm birth rate in this country, it's horrendous, right? It's at 11%. And it tends to skew wildly towards low-income women. And a lot of that is, it's economic, it's social, but it's unacceptable. And so we have been working for the last 2 or 3 years in the group prenatal care space. And the basic idea behind group prenatal, and we do this with a lot of models. We've got childhood obesity models. I mentioned the diabetes prevention program. But the magic of a group is you can deliver clinical content to a group, right? The same content they get one-on-one, but that group bonds if they have the same condition, right? And they support each other. And there really is a secret sauce in group sessions for certain kinds of conditions. So the evidence behind group prenatal care, just to give you some numbers on this, women that participate in group prenatal care, there's a 30% reduction in preterm births and a 50% reduction in rapid repeat pregnancies, which means less neonate, much healthier babies, and healthier families. So this is one where we rolled it out initially after some clinical studies on our own, and then decided that we weren't the ones that should be scaling this, right? United spent a lot of money developing a program, but in the end, we turned it over to the March of Dimes. So back to my comments on partnerships. What's the best entity in this country to roll out a healthy baby program? It's a not-for-profit that's trusted. And so really, this is just a partnership now with the March of Dimes where we turned all the assets over to them, and they're rolling this out state by state. And the last example I'll give you, and then I'll turn to questions, is another one where we're trying to extend effective care, and it's low tech. And this involves EMS workers. So one of the issues that we have in this country is that people that have chronic conditions, especially elderly populations or low-income populations, they just don't get to doctors. They can't get out of the house, or they won't get out of the house for social reasons. So we've been doing some work, and we've done some studies specifically in Kansas City, where we used EMS workers who have clinical license, right? They can draw samples, they can do environmental scans, they can get someone to a specialist if they need it. And we took a population of very sick, non-compliant diabetics who weren't getting to any visits. And we used EMS workers to go set up appointments and come to their house. We had an 80% acceptance rate. And why is that? Because people trust the EMS, right? They're in uniform. They're from the neighborhood generally. And they come to their home. And what we found is in about 60% of the cases, it resulted in a follow-up visit. People left the home on the advice of that EMS after they had actually conducted an exam. So low tech, really simple, but also incredibly inexpensive, right? You think about it from a health system standpoint. We pay the EMS worker $50 to go to that home and do an exam and have a conversation. So I will I'll close there. I hope I gave you some good context, and I'll open it up to questions if we have time. Thanks.